Yes, I can. It sounds great.
Okay, thank you.
Yes.
Thank y'all for joining us today. I have Dr. Atkinson here presenting. He is our maternal medical director at UMC and our MFM, and he will be going over hypertensive disorders of pregnancy. At the end of the presentation, I will post a link so that you can fill out the CNE evaluation. Just make sure that you fill this out so that you can get your CNE credit.
Good morning, everyone. This is Bill Atkinson. It's going to be a presentation on hypertension. This CMQCC, if you're not familiar with it, I would encourage you to research it. It's a great resource for medical conditions as well as obstetrical conditions that we all encounter in our careers. It's a great resource for quality. These slides are from their toolkit that they provide. The slides have been modified, though. Moving forward to the first slide, objectives: to know the impact of hypertensive disorders, define some new terminology and understand diagnostic criteria, describe the management of hypertension, identify systems of support on your unit for patient families before, during, and after hypertensive disorders of pregnancy. Maternal hypertension obviously is increasing. This graph demonstrates that from 1993 up to 2014, particularly in California, as well as in the United States. They've shown a steady increase. This slide is from the CDC. This is describing gestational hypertension, pre-eclampsia, eclampsia, as well as chronic hypertension. Changing for improving the healthcare response to preeclampsia. This is an expanded scope to address all hypertensive disorders. ACOG definition of severe hypertension actually changed with some explanation for consideration of treatment at even lower borderline values. This is a relatively new stance, and we'll talk about it a little bit more, but they're now suggesting that the criteria for treatment should even be lower than what we've established in just the recent past. Talk about some about low-dose aspirin for prevention, and then the long-term follow-up after patients have had conditions of hypertensive disorders in pregnancy. So it's a spectrum of hypertensive disorders, and on the right of your screen, you can see all the different conditions that have been described, from chronic hypertension to atypical preeclampsia and preeclampsia with severe features. We went from mild, moderate, severe preeclampsia to severe and non-severe, and now the definition is preeclampsia with severe features. Words like toxemia and pregnancy-induced hypertension have pretty much gone away. Guidelines for management: first, you have to recognize the symptoms and the diagnosis. Control blood pressure. Seizure prevention would be one of our targets, and delivery at 34 weeks beyond with severe features, 37 weeks with preeclampsia without severe features or even gestational hypertension, and then the postpartum surveillance. We're going to be looking at these 4 R's: readiness, recognition, response, and reporting. In readiness, every unit should have preparations of rapidly available medications, which has been an obstacle sometimes in hospital settings. Education for staff as well as patients. Simulations is very important. You have to be able to recognize the patients that are at risk, whether it's screening, diagnosis, and classifications, prevention approach. Response, every event and case, management, treatment, patient education, and then even reporting with debriefs, QI measures, and documentation. So first, readiness, risk factors, implementation. Risk factors for preeclampsia has been very well described over the years. Obviously, a prior history, multiples, chronic hypertension, pre-gestational diabetes, lupus, obstructive sleep apnea, no lips, gestational diabetics, BMIs greater than 30, antiphospholipid syndrome, maternal age, thrombophilia, and even assisted reproductive technology. The Joint Commission has established what they believe should be the bundle checklist to guide in this toolkit's implementation. First, evidence-based procedures for measuring blood pressure. This is very important. We're going to talk a little bit more about that. Evidence-based procedures for managing pregnant and postpartum patients with severe hypertension. Provide education to staff, providers about hospitals' protocols, which that's going to be one of the primary focuses. Conduct drills at least annually, review severe hypertension and preeclamptic cases, and provide printed education to patients and family members. Recognition and accurate blood pressure measurement, diagnostic updates. Accurate blood pressure. This is kind of one of my personal focuses. Accurate blood pressure measurement is essential in order to avoid over-under treatment, minimize factors that decrease accuracy as far as correct cuff size. Severe range blood pressure obtained with an automated blood pressure device should be validated with a manual and evaluate blood pressure trends versus isolated values. I personally have an issue with patients that are in the hospital, how their blood pressures are taken. I encourage the patient to be sitting on the side of the bed in a relaxed position and with feet touching the floor, and hopefully to be able to do those consistently. When we take blood pressure, sometimes sitting, sometimes lying, supine, sometimes on their side, it's hard to see a track and trend pattern develop and know what we should treat and not treat. Quality improvement opportunities to improve recognition. These are kind of the classic symptoms, but missed symptoms, we just didn't see it, whether it's headaches, elevated blood pressures, abnormal fetal monitoring, blurred vision, low oxygen sats, severe pain, altered behavior, bleeding, anemia, coagulopathy, shortness of breath, abnormal lab values. I've highlighted headaches and blurred vision. These can sometimes be the most challenging as far as to determine if this is just simply a symptom associated with pregnancy versus an underlying pathological explanation. Misdiagnosed, obviously saw it as something else, whether it's seizure disorders, gallstones, maybe an explanation, or thought it was an explanation for right upper quadrant pain, chronic hypertension, new onset asthma versus actually pulmonary edema, and postpartum psychosis. This slide you can actually get a copy of if you like, if you go to their website. I think it's very valuable. Looking at different triggers regarding blood pressures, which you can see in the left upper box. Severe triggers, those should actually be altered maternal mental status, which is maternal agitation, confusion, neurological, which could be a severe headache that's unresponsive to medication, visual disturbances, which again, blurred, impaired vision, physical, maybe shortness of breath or epigastric pain. Abnormal maternal assessment, particularly focused on blood pressures, sustained for 15 minutes, or if the nurse is clinically concerned with the patient, request provider evaluation, look at those particular blood pressures, greater than 160 systolic, diastolic greater than 110. Recommended to treat with antihypertensive agents, and then initiate magnesium for seizure prophylaxis, 4 to 6 gram bolus, 1 to 2 grams per hour for maintenance, and 6 gram bolus may be recommended for a BMI greater than 35. Just a pearl, 40% of patients with new onset of hypertension or new onset of proteinuria will develop pre-eclampsia. ACOG's definition of pre-eclampsia, typically described as greater than or equal to 140/90. It's described in their bulletins as greater than these systolic, diastolic on 2 occasions at least 4 hours apart. That's obviously a little challenging to do if you see a patient in the office, but that is their definition. Or another is systolic blood pressure is 160, diastolic 110, confirmed in a short interval of 15 minutes. Proteinuria is defined as 300 milligrams and a 24-hour collection, or what's becoming more and more popular is urine protein creatinine ratio of greater than 0.3. Dipsticks we never use to quantitate, but they've reported 2%. Other lab evaluations, CBC, liver functions, creatinine, bilirubin, glucose. Uric acid is optional. It's one of the older labs used to follow preeclampsia. I personally have still found it valuable, but it's not always incorporated in the lab test. For patients with acute abdominal pain, obviously looking to consider the possibility of pancreatitis, and ammonia is checked if you have a suspicion of acute fatty liver. A diagnosis of preeclampsia with severe features, low platelets, impaired liver, renal insufficiency, pulmonary edema, new onset of headaches, unresponsive to medication, visual. The blood pressure is again defined there, but antihypertensive treatment should be initiated within the hour if severe blood pressure is confirmed after the 15-minute repeat. A confirmed blood pressure should be treated with antihypertensives within an hour, and then magnesium started immediately following the antihypertensive therapy. This is on the presumption that one is obviously moving towards delivery. If there is just a one-type treatment with very early gestational ages, that will be a clinical judgment. The diagnosis of chronic hypertension and superimposed. Chronic is hypertension diagnosed or present before pregnancy or before 20 weeks, or hypertension diagnosed for the first time during pregnancy and does not resolve in the postpartum period. Superimposed preeclampsia with a history of hypertension before pregnancy or before 20 weeks. Pre-existing proteinuria prior to 20 weeks should be suggestive of chronic renal disease, often associated with long-standing hypertension or diabetes. This is why it's important to obtain baseline laboratory studies for patients at risk, so you have something to compare if your clinical suspicion suggests superimposed preeclampsia. The spectrum of preeclampsia is variable. Preeclampsia with severe features, which can be associated or overlapping with HELP. HELP syndrome, though, can occur as an isolated event, and then obviously the concern is secondarily is risk of seizures, eclampsia. HELP syndrome associated with increased risk of adverse outcomes, have a higher risk of placental abruption, renal failure, hematomas, preterm delivery, fetal maternal death. There is actually an increased risk of recurrent preeclampsia. So the next R is response. Again, blood pressure control, seizure prophylaxis, delivery or expectant, depending on clinical circumstances and gestational age. And then the other is simply, and most importantly, sometimes that we don't focus on enough, is our postpartum surveillance. Hypertensive emergency in pregnancy as well as postpartum. This applies to all hypertensive disorders of pregnancy, chronic, gestational, preeclampsia, with or without severe features. Blood pressures greater than 160, systolic, diastolic 110, repeat 15 minutes. If blood pressure remains in severe range, then obviously proceed with treatment of hypertensive. Controlling blood pressure is the optimal intervention to prevent deaths due to stroke in women with preeclampsia. Take this opportunity to emphasize that the blood pressures that are recommended to have intervention in pregnancy are sometimes different than those in a non-pregnant state. Their autoregulation is different, and they're at much higher risk for stroke than in a non-pregnant patient. Addressing critical maternal blood pressure at the time of presentation, whether the patient has preeclampsia with severe features, severe gestational hypertension, superimposed chronic hypertension, or exacerbation. Exacerbation is not known. In other words, you don't know the situation, but you're encountering severe blood pressures. The initial stabilization of the patient should be timely treatment which the three most common antihypertensives are labetalol, hydralazine, and nifedipine, and obviously magnesium for prevention of seizures. So again, these are protocols that are fairly standard through ACOG, SMFM, looking at labetalol, hydralazine, and nifedipine. The nifedipine is one that can be used as an oral agent. These are the dosages. Looking at time of onset is very important. Labetalol having the most rapid onset and peaks at a shorter period of time. Underneath that, you have the maximum dosages that can be used and their mechanism of action and particular side effects. One of the things that has to be considered is your choice of agent, and particularly like patients with asthma, you may not want to choose a beta blocker with with labetalol. And then keeping in mind with the hydralazine, you definitely can have a rebound tachycardia. So an algorithm is established here. Blood pressure shows every 10 minutes to the blood pressures for 1 hour, then every 15 minutes, every 30 minutes, every hour. This is not a rigid protocol to follow, but certainly is a suggestion in the ACOG bulletin. And then again, to the right of the screen, you can see the regimens that can be used with each particular agent. The interval to repeat the blood pressure is different because of the different onset and the duration of the medication, with labetalol being 10 minutes, where hydralazine can be 20 minutes in between. So what's the focus? The focus is preventing stroke with preeclampsia. This is a very interesting slide. And basically demonstrates that the significance is probably on the systolic blood pressure rather than the diastolic. If you look at these two different studies, it's showing that what was the blood pressure pre-stroke with maternal mortality from stroke or preeclampsia. Well, the range there for systolic blood pressure is 134 to 238. Again, emphasizing that there is a significant range of blood pressure, systolic wise, that can lead to a stroke. It's not just simply what we define as severe, greater than 160. So if you look at the next line, the systolic blood pressure that was greater than 160, 96% of the patients had that. The diastolic range was 79 to 148, and only 65% had a blood pressure greater than 110. The other article that's quoted here, the range of systolic blood pressures was 159 to 198, which 95% of the patients had a blood pressure greater than 160. And in their study, the diastolic blood pressure only was 12% greater than 110. So again, the focus probably should be somewhat on systolic, but obviously still would treat diastolics in the severe range of greater than 110. Borderline severe range blood pressure recommendations, physician's notification of blood pressures that are severe, physician evaluation of the patient, continuous electronic fetal monitoring. If these patients are treated, what has been suggested here, that initial observation for a minimum of 24, 48 hours, I would probably suggest longer than this, but again, that's just my clinical comfort level. Vital signs and symptoms assessment every hours for a minimum of 24, and serial laboratory studies. But then, as we stated earlier in this presentation, there is consideration of actually lowering the threshold. What they've suggested here is a blood pressure greater than 155 systolic and a diastolic greater than 105. So we'll have to see where the future leads, if that's the reestablished thresholds or not. Magnesium, obviously its primary focus is prophylaxis for seizures, eclampsia, preeclampsia with severe features, and severe gestational hypertension. all cases of severe defined as, again, greater than 160 or 110 diastolic, that's sustained, regardless of the classification. In other words, as far as what label you want to put them, whether it's gestational, preeclampsia, or even superimposed chronic. Magnesium is not universally recommended for preeclampsia without severe features. You would find some differencing of this. Some feel like if you've made the diagnosis, prophylaxis should be initiated. But most experts in the field feel like the primary focus for magnesium should be on severe preeclampsia. Now, magnesium is not an antihypertensive medication. Yes, it may cause some vessel dilation within the CNS, which can be a benefit regarding less risk of stroke, but again, it is not antihypertensive. What this is demonstrating is that over time of the magnesium, you really didn't see a change in the systolic blood pressures nor the diastolic with infusion of magnesium. Eclampsia, and this is out of the ACOG bulletin, is defined as a new onset tonic-clonic focal multifocal seizures in the absence of other causative conditions such as epilepsy, ischemic cerebral intracranial hemorrhage, or drug use. Occurs in approximately 1 in 1,000 deliveries in the United States. Mortality from eclampsia range from 1% as high as 15% in developing world. Characterization of symptoms immediately preceding eclampsia. This is a study that had 46 cases of eclampsia, 1.4%. The most common symptoms, headaches and visual disturbances, 80%, 45%. 20% of women with eclampsia reported no neurological symptoms before the seizure. So these are important statistics, realizing one, there were not symptoms in 20%, and headaches and visual disturbances appear to be the two more common symptoms. And it's easy clinically when you know the patient has that truly debilitating headache and there's absolutely defined visual disturbances. But it's more challenging when the patient has had headaches, they're nonspecific, they're not debilitating, and they do respond to medical therapy. But that's not always as easy to distinguish as sometimes the literature may insinuate. Gestational age in preeclampsia, onset prior to 34 weeks, is more often severe and should be managed at a facility with appropriate resources for management of these type of patients. Induction of labor at 37 weeks is indicated for women with preeclampsia without features and gestational hypertension. That's an important take home because I think, again, there's a tendency to treat gestational hypertension less aggressive. The pearl here is in patients with preterm preeclampsia, less than 34 weeks with severe features, can rapidly progress to significant maternal morbidity and mortality. I think if you've been in the field very long, you've seen this. When it's the really early onset of preeclampsia, it has a tendency to be more rapidly severe than this slow progression we see later in the third trimester. Considerations for expected management of the clinically stable patient with preeclampsia in less than 34 weeks. So maternal stabilization, blood pressure control, seizure prophylaxis, adequate cardiopulmonary function, in the absence of the criteria that would be used to define severe preeclampsia with severe features. I've highlighted seizure prophylaxis because we typically don't necessarily have that as one of our first steps. In other words, we have the late second trimester with concerns for severe preeclampsia. We focus on the blood pressure control. If we have one that is somewhat unstable and we're trying to get the 48 hours of steroids, in those cases, we will use magnesium prophylaxis, but it's not necessarily one of our first go-tos. Additional management, consultation in ICU, MFM, anesthesia, critical care, and again, administration of corticosteroids for fetal lung maturity. Management of suspected severe preeclampsia or severe features. Proceed with delivery if any of the following are present: recurrent symptoms of severe preeclampsia, recurrent severe hypertension despite therapy, HELP syndrome, abruption, or severe growth restriction with oligo or abnormal monitoring or ultrasound Dopplers. Outpatient management of preeclampsia. This is sometimes rather controversial, but should only be considered for patients that meet all following criteria: no severe features, stable disease, reassuring fetal well-being, able to be followed in a recommended outpatient management plan. Hospital admission is necessary for any patient who develops preeclampsia with severe. If the patient is greater than 34 at the time of diagnosis, but has severe features, then obviously proceed with delivery. Those with preeclampsia without severe features should be admitted and delivered at 37 weeks. At the time of discharge, women families should be given clear written educational materials outlining signs and symptoms to alert them when they need further assessment and requiring return to the provider's office or hospital. Blood pressure monitoring by the patient should be encouraged whenever possible. I'll take a moment here to say that has become one of our focuses on being able to obtain blood pressure equipment for our patients, and I think we're moving in a very positive direction for this. I'll let you put a plug in there. What are we using?
We go through the breast pump depot and they help us get blood pressure cuffs to our patients, typically free of charge or very little cost. If you are interested in something like that and getting set up with the breast pump depot, we can get you our contact for that and get you started. I'll type in my email in the chat here and you can send me an email and we'll get that to you.
Thank you, Jesse. So patient education materials, very important. We've actually started posting the middle poster there in our clinics, and it certainly has generated good discussions with our patients and have made them more informed, including the post on the right of postpartum preeclampsia. Late postpartum eclampsia, greater than 48 hours following delivery, up to 6 weeks postpartum. It actually accounts for 26% of cases with eclampsia. 78% had no antepartum hypertensive diagnosis. Let me repeat that. 78% had no antepartum hypertensive diagnosis. That's a pretty substantial number. And the magnitude of blood pressure elevation does not appear to be predictive of eclampsia. These are two really important facts as far as the risk of eclampsia postpartum. The most common presenting symptom was headache, occurring in 70% of these patients. Other prodromal symptoms include shortness of breath, blurred vision, nausea, vomiting, edema, neurological deficits, and epigastric pain. Tomorrow we have our OB-M&M, and this is actually going to be one of our focuses and discussion is the management of these postpartum patients. And I'll also just give some additional information how we are starting to follow these patients. It may vary in your facility, but postpartum patients that have required severe hypertensive treatment, we tried that they're seeing within 3 days. We're considering extending that to 5. In patients with labor of hypertension, labeled with hypertension and did not require treatment within 7 days, possibly up to 7 to 10 days. So we're trying to put a rather rigid practice in place for follow-up of these patients, so hopefully they don't drop through the cracks. Postpartum patients who present to the emergency department and have trigger or clinical hypertension or suspected preeclampsia should be assessed by and or admitted to obstetrical service. This is a focus that we actually have. We're in education process right now, working with our ED, that we are automatically consulted on any patient that presents the ED for whatever their symptom in that 6-week window. Pre-eclampsia in the emergency department, the most important first step is to identify whether the patient has been pregnant in the last 6 weeks. If yes, assess immediately. ED/OB clinicians should be notified of the patient's arrival immediately to expedite the evaluation. Tell us if you're pregnant or have been pregnant within the past 6 weeks. Come to the front of the line if you have persistent headaches, visual changes, history of preeclampsia, shortness of breath, history of high blood pressure, chest pain, bleeding, weakness, severe abdominal pain, confusion, obviously seizures, fever, chills, swelling in the hands. We have a very, very busy triage facility here at UMC. So obviously, patients will present there more often than the ED or other UMC facilities, but it certainly happens on a more frequent basis than one would expect. Pre-eclampsia in the emergency department, the trigger blood pressure is the same, but again, this is lower than what most non-OB providers are accustomed to. Education needs to be emphasized on what our blood pressure cutoff is. ED personnel should be familiar with the risk factors, signs, and symptoms of postpartum preeclampsia and eclampsia. Develop a workflow for your hospital between your ED and OB teams. ED clinicians should focus on maternal resuscitation, blood pressure management, seizure prophylaxis, and getting OB team involved immediately. Long-term risk from hypertensive disorder. Seems to be a relatively hot topic at this time. Patients with a history of hypertensive disorders in pregnancy or postpartum period increased risk for pulmonary edema, cardiomyopathy. Those in particular with low oxygen saturation, shortness of breath, or dyspnea should be evaluated and treated in the following. Patients should be counseled that hypertensive disorders increase the risk of future cardiovascular disease, and primary care providers should be made aware of their pregnancy history. This is studies are ongoing showing that this is very substantial, that patients that have had hypertensive disorders in pregnancies have a significant increased risk of cardiovascular disease later in life. Talking with families and the patients about the disorder to ensure their optimal physical and emotional well-being. Education is key to identify early warning signs, seek medical care, acknowledge the impact of hypertensive disorders on women's lives and mental health, promote effective communication education, rely on evidence-based communication protocols when sharing information to ensure a woman-centered care, promote shared decision-making, embrace the diversity of family structures and cultural practices. I think this is more important than what we have a tendency to emphasize. Patient populations can vary dramatically, and sometimes how we manage these patients create a significant burden on families, as well as patients that have younger children. And so it has to be taken into consideration when we're establishing management plans, as well as follow-up regarding transportation and availability. Prevention, low-dose aspirin has pretty much become standard now on patients who have identified risk factors. Effective mechanism for prevention of preeclampsia, certainly in high-risk patients, mainly those with a history of preeclampsia. Anti-inflammatory, anti-angiogenesis, antiplatelet is its benefit. 81 milligrams per day prophylaxis is recommended for women at high risk for preeclampsia, initiated between 12 and 28 weeks, optimally before 16, should be continued daily until delivery. This may vary in the very near future. In Europe, the dosage is 150. In our patients that we've identified, certainly at high risk, we've started going to 162 milligrams because there's not a 150 milligram dose available in the United States. So it's basically just taking 2 pills of the 81 milligrams. So again, this is showing the high risk and the moderate and the low, but it got cut off. The high we'll focus on is a history of preeclampsia, multiples, chronic hypertension, diabetes, renal disease, autoimmune, and combinations of multiple moderate risk factors. Um,
That way.
the low was previous uncomplicated full term, not to recommend. But pretty much anybody else, it's recommended for consideration, and particularly in the high risk category. That's the category again we've chosen in selected situations to use a higher dose than has been previously suggested. So one of the last R's is reporting, debriefs, case reviews, process measures, outcome measures. I highly compliment UMC. I think they do an outstanding job in following up these cases, collecting data, and hopefully making changes in the future. Debriefs and case reviews, debriefs, multidisciplinary reviews are foundational learning for creating a highly reliable clinical team and maintaining a culture of safety. Debrief allows the team to reflect on performance, problem solving in real time, and should become a routine part of activities on the unit. We have really focused on the debriefs, not just in hypertensive disorders, but in other circumstances. And I think it's made a substantial difference in our overall care. Case review, we follow through with these cases that we select out that are presented and deep dived and look at situations that we can make a difference in our care in the future. Process measures, outcome measures, timely treatment of hypertension. Again, this is one of our focuses. We look at each case carefully regarding were they treated appropriately in the appropriate time, fashion, appropriate manner. Most important action is to reduce severe maternal mortality and morbidity, and rapid, timely treatment is the first line of defense in these situations. So in conclusion of the 4 Rs that we talked about, the readiness, the recognition, the response, and reporting, again, this toolkit is available through CMQCC. The protocols, algorithms are available also there. And I think they're great posters to place around in your labor and delivery for ongoing education. I do it to
Yep. Does anyone have any questions for us? Y'all can just unmute and ask, or we will look in the comments as well. And I will add in the chat the evaluation link. So just make sure that you fill that out so that I can give you your CNE credit, and I will get that email to you. Yes, we can get you a copy of the slides. Yes, if you want a copy, just type in your email in there, and then I will send that to you. Or on the evaluation, you can put that in the comment section as well.
While we're looking at that, I'll just go through some additional parts of this toolkit that are available. Again, this is one slide that I showed. This is another algorithm for suspected preeclampsia that's very helpful. The treatment algorithm is also another poster slide that's available. The one that's already incorporated in the presentation. And then the acute treatment, particularly with magnesium dosing. This would be a very important poster, I would think, available in your labor deliveries. Sometimes, rarely, but possible, you encounter a situation that's unresponsive to magnesium and continue to seize. Well, this slide poster provides the next line of therapy and the actual dosages. Again, this is the eclampsia algorithm. So I'll stop there.
Hey, I think that's all. Give me just a few minutes to get that link posted, and I will put it in the comment section. And then I will get those slides and the C&Es sent out to you guys, and just let us know if y'all ever need anything else from us. Thank y'all and have a great day.